Hi everyone, welcome back to PIC University. My name is Harman Shavla, and today we'll be talking about acid-base balance in the body, and more specifically how it applies to the pediatric ICU population. Here's going to be our course outline for today. We're going to define normal pH. We'll go into states of acidosis, states of alkalosis, and then we'll put it together with some practice questions. And of course, these practice questions will be available in print as well. And let's get started with that. So in general, when we start thinking about normal pH, we think about it as a spectrum where 7 is considered balanced pH. And that scale that we look at ranges from 1 all the way up to 14. Well, when we look at the human body actually operates in a much more narrow window than this, where the normal pH within the human body is 7.4, and the vast majority of normal operation that occurs in the human body is between a pH of 7.35 all the way up to a pH of 7.45. Once we start getting outside this realm, we really start looking at imbalances of acid and base, and as a result we can start having physiologic consequences within the body. So to this end, we will start looking at acidosis first. So acidosis itself inside the body is defined as a pH less than 7.4. Now, to some degree, we can accept slightly lower pHs, but again, once we start crossing over the 7.35 range, that's where we really have to start looking at what the causative agents are. The underlying reason for the acidosis can be variable. It can either be respiratory or it can be metabolic. Generally, when we look at a respiratory reason for acidosis, that's a state of hypoventilation, where the patient isn't effectively exchanging gas, and it leads to an overall increase in the carbon dioxide content of the blood. When we look at metabolic causes of acidosis, it really fundamentally boils down to a decrease in bicarb. And again, this decrease in bicarb can be polyfactorial, and we'll have a separate lecture on going through the differential diagnosis of metabolic acidosis. So again, for our lecture, we're going to define acidosis as a pH less than 7.4. Now, when we start looking at acidosis, we'll shift over to the respiratory side. When we get respiratory acidosis, the body has natural mechanisms by which it starts compensating. And so you can have respiratory acidosis, and the compensatory mechanism to that will be a metabolic alkalosis. And what this effectively means is the body will start retaining bicarb, and so you'll see a compensatory rise in the bicarb within the blood. Alternatively, if we have a metabolic acidosis, the body's compensatory mechanism is to develop a respiratory alkalosis. And what this basically means is that the body will start exchanging more carbon dioxide, minute ventilation will go up, and the body's CO2 will go down. It's important to note that we can never compensate more than the original defect. So that's to say that if we have a respiratory acidosis, we can't compensate with metabolic alkalosis so that our pH rises above 7.4. The next important thing to realize is, what are the physiologic effects of acidosis? Well, there's a few, and what we basically look at is a decrease in overall cardiac function. We see a change in our hemoglobin dissociation curve as well. So what this basically means is that the hemoglobin molecules themselves will start having a right shift, as we see right here. And what this right shift of the hemoglobin dissociation curve means is a decreased affinity for oxygen. This means that the hemoglobin molecules within the body are going to unload oxygen a lot more than they normally would. They don't bind quite as strongly, so they'll dump that oxygen into the tissues. One easy way to think about this is that if you're exercising and your muscles are building up lactate and becoming acidotic, do you want your hemoglobin molecules to hang on to oxygen, or do you want them to dump that oxygen molecule off into the muscle? Well, again, in that acidemic environment, the hemoglobin molecule is more likely to dissociate from oxygen. The other thing that's extremely important that I really want to bring up is this point right here, is an increase in pulmonary vascular resistance as a result of acidosis. So states of acidosis promote an elevation in pulmonary vascular resistance. So when we have a pulmonary hypertensive crisis, one of the fastest and most effective things that we can do to it is really get some an increase in our switch over to a state of alkalosis, I should say. And in that regard, we're going to start decreasing that pulmonary vascular resistance. So now we're going to start talking about alkalosis. And for the purposes of the human body, when we're talking about alkalosis, we're going to define it as a pH greater than 7.4. The underlying reason for the alkalosis, again, can be respiratory or metabolic in nature. When we're talking about respiratory alkalosis, we're talking about a state of hyperventilation. This is when the patient is, quote unquote, blowing off too much CO2. So as a result, the blood value of the CO2 actually goes down. When we look at metabolic alkalosis, this is a state in which the body is retaining bicarb, and overall the blood value of bicarb starts to increase. So again, when we're defining alkalosis as a pH greater than 7.4, we can have two different sources of compensation. If the underlying reason is respiratory alkalosis, the compensatory mechanism to this will be a metabolic acidosis, meaning that the body will work to decrease the bicarb in the blood. If the underlying reason for the alkalosis is metabolic in nature, saying that we have a primary metabolic alkalosis, the compensatory mechanism will be a respiratory acidosis, which means the person will be decreasing their minute ventilation and thereby increasing the amount of carbon dioxide in the blood. Now, what are the physiologic effects of this? Again, similar to what we talked about with the hemoglobin dissociation curve, we wind up having a shift, but this time it winds up being a left shift. And what this basically means is that we now have an increased affinity for oxygen to the hemoglobin molecule. The hemoglobin molecule binds more tightly to that oxygen than it would in an acidemic state. And the other thing it does is it also decreases the pulmonary vascular resistance, and this is something that we just touched upon in the previous slide. So putting it together, here's a real basic kind of algorithm that can be used. The first thing you should do when you get a patient in a blood gas is figure out what is their pH. Is their pH less than 7.4 or is their pH greater than 7.4? That in itself is going to define the state of either acidosis or alkalosis. Then, based off of that, we can figure out, well, is this a respiratory cause or is it a metabolic cause? And the values that we look at there are the bicarb levels and the CO2 levels. And with that, we're going to be able to define whether it's a metabolic acidosis, respiratory acidosis, or a metabolic alkalosis or a respiratory alkalosis. There will be interesting cases in which both the bicarb and the CO2 contribute to it, meaning that we have a mixed metabolic or respiratory acidosis or alkalosis as well, and the criteria for those are listed right here and here. So here are some practice questions that are worth doing. I will leave these up. Feel free to pause these videos and go through these questions and effectively just try again using the algorithm from the slides previously to follow the blood gas and really figure out what the acid-base defect is. Once again, thank you for participating in this video. As always, if there are any questions or comments or suggestions for other videos, we're always open to them. And don't forget to hit like and don't forget to subscribe. Thanks again.